Hello, and thank you for joining us for this segment addressing assessment of risk. Is it time to implement risk stratification protocols in the management of our patients? I'm Dr. Sean Studer from SUNY Downstate Medical School in Brooklyn, New York, and I'm joined today by Dr. Paul Forfia at Temple University in Philadelphia and Dr. Martha Kingman at University of Texas Southwest. Thank you both for joining me for this segment. So I wanted to start, Paul, by talking to you about how do you perform the risk assessment in your patients, and along with that, do you expect them to meet certain risk parameters, such as low risk status by the first follow-up after a treatment initiation or change?
Well, it's a great question. You know, I'm still fundamentally a clinician, and I think along clinicians' lines. So I'll answer it in the following way: that when I'm assessing risk of a patient with PAH, I'm starting from top to bottom, and what I mean by that is I'm going to ask them what their functional ability is in their history of present illness. So I want to try to get what their functional classification is during that history of present illness. I'm then going down to the physical examination, and I'm looking to see if they have the presence or absence of findings of right-sided heart failure. Moving to the next phase in our assessment would be the walk test. And I'm actually literally visualizing what our note looks like. And it starts with obviously the HPI, and then we go to the exam, and then we go to the walk. And so now I'm going to look at that walk distance and see if they've met a certain threshold walk distance and what their vital signs, like their heart rate, blood pressure, and oxygen saturation was during the walk. And then lastly, I'm going to look at their cardiac imaging, namely their echocardiogram, which we do not do every time we see the patient, but we do an echocardiogram every 6 months. And we're looking to see that that right heart size and function are moving into a normal or near normal range on therapy.
Great. So if you have a patient who you'd say is largely falling into a moderate risk category, and you make an adjustment to therapy, or perhaps adding an additional medication, are you very explicit either in your mind or your notes or communication with the patient about what your timing goals are for changing those parameters?
Yeah, it's a good question. I think that we do expect to see movement in a positive direction from the functional class, the exam, the walk distance, the echo. You're obviously not going to see those changes in a matter of days, but certainly at 3-month intervals with escalation of therapy, you really should be seeing positive change occurring. And so if we've implemented a therapy in January of 2018, and then by March or April, we see the patient back and none of those parameters have changed for the positive, that's concerning to me. And I'm going to know at that point that they're not moving in the right direction. That has given them more than ample time to respond in a positive way, and they hadn't. So I'd say 3 months would be a reasonable cutoff where you'd say you would expect to see change, and if you don't see that positive change, you're going to have to reconsider further escalation of therapy.
Sure, and that's a great point. And as we know, a lot of patients are somewhat resistant to making multiple changes to therapy over a short period of time. And perhaps their better understanding of a risk assessment could help move them mentally to a place where they might be more accepting of these. So, Martha, do you share the risk assessment scores or profiles that they fall into with your patients when you do them?
I do, not in every patient, but in certain situations I do. One example might be a patient who's doing very well and has met all the low-risk criteria, but very concerned still about where they are and what their prognosis might be, and worried about that quite a bit. I'll pull up their risk assessment and show them, really happy with where we are. Every one of these things, your walk test is great, your functional class 1 or 2, your NT-proBNP is normalized, you have no signs of right heart failure, meaning no lower extremity edema. We're very happy and comfortable with where we are in your therapy. So that can be reassuring for patients.
Good. So it sounds like you individualize it, though, a bit, right? It's not
I
someone
do.
comes in each time and, if they had diabetes, you might tell them their hemoglobin A1C because that's a standard that everyone seems to know. But in this case, you couch the message a little bit differently based on what you think they can manage in terms of the information.
And all patients, as we know, are different on the amount of information that they want to get as well. So you have some people who are really aggressively seeking out information, and they're on the internet and they're reading everything and they want that information. And so I definitely share it with those folks. And then occasionally we'll have a patient who we're really concerned about, and we want to put them on a parenteral therapy, an IV infusion. And as would be expected, a lot of resistance from that. It's a life-changing therapy for sure. But in that case, you can also use it in the opposite way and say, these are the things that we know we need to get better for you to be living for a long time, such as your NT-proBNP and your walk test and your functional class, and then to show them, we've got to get this better. And sometimes, again, seeing that in black and white can be pretty powerful.
I think so, and hopefully it shows them some reflection of our thinking, because many centers, the patients hear their 6-minute walk distance when they finish the test. They may discuss their functional class when they know. So I think this gives them perhaps a fuller picture. A potential area of challenge is, what do you do when some things fall into a good category, like a bunch of low-risk parameters, but then you have others perhaps in moderate risk, or maybe even 1 or 2 if it happens to happen up in the high risk. Paul, how do you manage that when you have things that aren't neatly lined up, which is not uncommon?
Right, it's a great question. I mean, I think when you have this supposed conflicting information, you have to, this is where really understanding the disease becomes very vitally important. So I'll construct briefly 2 scenarios. One is where a person feels relatively well in their daily life. Their walk distance is actually very good. Say their walk distance is 600 meters. But then on their echocardiogram, and perhaps also their BNP level are abnormal. Their right ventricle is still significantly dilated and dysfunctional. Their BNP level is still in the 200s. And so then you have to understand the disease. And you say, well, how could a person who has residual moderate right heart dysfunction and cardiac strain as evidenced by a high BNP level, but yet they feel well in their daily life and they have a good walk distance? And the answer is that these are submaximal assessments like functional capacity and walk distance. The person may be young, they may be, have a lean body build and a strong skeletal musculature, and they can easily walk 600 meters, but that person's long-term outlook with residual right heart dysfunction and an elevated BNP level is not good. And so since the pathophysiology of the disease is still so rooted to right heart dysfunction, that person, to me, with that residual right heart dysfunction, is going to get bumped up into that intermediate or high risk class, and I'm going to treat them accordingly. Of course, we have to counsel them, right? Because it may be surprising to them that they're not doing as well as they think they are. But when we really explain what's going on, nearly always we can get the patients to understand that. The second and very brief scenario is a person who has clear evidence of right-sided heart failure, but their BNP level is normal. And there's one scenario where we see that repeatedly, and it's in a patient who's morbidly obese. And so that would be a supposed low-risk feature, having a normal BNP level. But we know that patients with heart failure who are morbidly obese often have a normal BNP level despite being in heart failure. So in that case, that's an easier one, and we can immediately explain to the patient that their BNP level is normal or low, but it doesn't mean anything, in that it's a pseudo-low state, and the person is still in a high-risk category, and we need to move forward accordingly.
Yeah, another example of that is somebody whose walk distance is really poor, and if you didn't understand that they were having back pain or they had these other limitations, you might consider that to be a high-risk indicator, which certainly it wouldn't be in that situation.
That's a great point.
Mm-hmm.
Sure. So what I really hear you both saying, it sounds like, is that these risk assessments are important. They should be done serially, but you might want to weight some factors greater than others, because there may be things that when you really look at them, not just as numbers, right? We can't hand this to someone who doesn't understand the disease state and expect the number is always going to tell them what it tells an experienced PAH clinician, because you know what to do when one doesn't fit and you can explain it easily, or if it doesn't fit and you find it to be a less telling feature of their prognosis. So a very rich discussion on the topic. I appreciate both of your contributions, and thank you for joining us for this segment.